Orlando Medical Institute podcast.
Hi, my name is Felix Marquez. I'm from Orlando Medical Institute. Today's podcast that I'll be covering is a 3-part series on advanced 12-lead ECGs. Today's podcast of the 3-part series is going to focus on the cardiac electrolytes and a little bit about the anatomy and physiology. So let's go ahead and let's dive into this PowerPoint that I want to speak about. So I want you to know a lot of us rely a lot on the diagnostic of technology. So the machine itself, that technology that we have with us when we do a 12-lead as a paramedic is we rely a lot of times on that machine printing out and telling us what we have here is a STEMI. And then we put our eggs in that basket. We put all our eggs in that basket of the computer diagnosing the 12-lead. So I want you to know it is common for some of these machines to have some error. And the error factor could be anywhere from 15 to 50% error. So the machine is not always right is the bottom line. So we really and truly got to be able to read these ECGs manually. What I like to say a machine is good for is to kind of raise the eyebrow saying, oh my God, my machine is saying it's a STEMI. Well, let me dive into my ECG and look at it through kind of like a microscope to say, yes, this is a 12-lead or it's not. So I want you to know there is room for error with the machine making the decision of this is a STEMI or not. All right, let's dive into the anatomy and the physiology of the cardiovascular system. It's truly important to understand what truly makes that myocardium work. And it deals with two things specifically to keep it simple. It's electricity and contractility. So we hope that the electricity that moves through the myocardium stimulates the muscle of the heart, causes the contractility that gives us good cardiac output, right? So what's unique about the heart muscle itself, that we call it its own muscle, it has automaticity, the ability to generate its own electrical impulses. So the question is, how does that happen? Well, through these electrolytes that we're going to talk about here today in this podcast. So the electrolytes we're going to refer to today specifically is going to be potassium, sodium, and actually calcium. All right, and we might touch a little bit on magnesium. But those are the electrolytes that are so essential for good contractility of the heart and to keep the electricity flowing in a rate and a speed with the high voltage to allow great contractility that gives us good cardiac output. So when we talk about this, we're going to talk about, I want to get into first what these pacemaker cells, that's what I'm referencing. And it's all or none phenomenon. What does that truly mean? It means that either we all contract or we all stimulate contractility or we don't, right? So the ventricle action potential is what I'm referencing is generally split into 5 phases. 5 phases is actually 0, 1, 2, 3, 4. So 0 is a phase. And ironically, and pretty confusing, it starts not at 0. The action potential actually starts at phase 4. So it starts at phase 4 and it actually ends at phase 4. So that baseline that you're going to see if you actually look at an image of the action potential, the ventricles, that baseline is actually phase 4, okay? As it starts to depolarize and the electricity starts to move, you're going to start seeing a change in this waveform that we refer to the different phases. So let's start, and let's hone in on all 5 of those phases. Let's start where it begins, right? At the baseline, which is phase 4. What's taking place at phase 4 is actually calcium. The calcium is the dominant electrolyte, the dominant ion, all right? And it's at what we call its resting potential. So by far, more permeable to potassium than any other ion. And what do I mean by permeable? It means that potassium is actually more will move through this actual channel a lot easier and fluently in and out without any stimulation whatsoever. All right, so at rest, the potassium channels are open. And because they're open, and because this membrane is more permeable to potassium, it kind of moves freely. And what it's creating is creating an equilibrium. It's creating an equal balance inside as well as outside, okay? So we move now into phase 0. So what we're referring more, we just talked about the resting potential, right? Repolarization. Now we're going to get into the depolarization, which is essential and very important as well. Now we start hitting what's called phase 0. So phase 0 is now we call the fast depolarization. And what's taking place is the voltage gate of sodium is actually opening up. And it's responding to the depolarization, it's responding to the sodium influx. So once these sodium channels start to open, sodium now starts rushing in. And when sodium starts rushing in and we have this influx of sodium, it actually creates a domino effect. What starts to happen now is that all these sodium channels start to open, and they start opening quickly, and it's through the influx of sodium. That's the uniqueness of this, that how when one channel starts to open, how they all trigger that domino effect. So if you wanted me to put this into perspective a little bit, let's think of the SA node, right? Where does the SA node sit? We know it sits on the top of the right atrium. So it's not nothing that I could dissect the heart and say, hey guys, look, this is an SA node. No, it's that tissue of the upper right atrium, that area, that tissue of that area is where we refer to that tissue as the SA node, the sinoatrial node. So that area right there is where that phase 0 starts to take place, where those voltage gates of sodium channels start to open up, and now we start having the influx of sodium. Now when you start having an influx of sodium, it now triggers all the rest of the channels to start opening up. And when they start opening up, sodium starts rushing in. And sodium is, guys, predominantly a depolarizing ion. It is truly responsible for that voltage. It's the excitement cell. When sodium moves, cells become excited. Electricity is moving. That's why they call it a depolarizing ion. It creates the excitability of these cells to start depolarizing. All right? And I want you to know it continues, but it continues in a positive feedback direction, or better yet, a positive feedback mechanism that causes the fast and the steep depolarization. And that's key, guys, because as fast as it goes and as quickly as it can depolarize, then that tells me that I'm going to cause that muscle, the myocardium, to contract almost at the same time. And when that happens, that's what's going to increase the force of contractility. That's going to provide good quality cardiac output, okay? So now, ironically and very uniquely, I say, not ironically, that's probably a bad word, but uniquely, when sodium rushes into this channel, automatically, as quickly as sodium went through that channel, is as quickly as these channels become inactive. All right? They're inactivated. They're no longer able to depolarize again. So once the sodium moves to that one channel, boom, that channel is now deactivated. It's no longer active. So because it's no longer active, there is no way that sodium can rush back in and create depolarization. So when those cells do that, it now has to go through a process. And the process, after it depolarizes, it has to repolarize so it can regenerate that channel to open up so sodium can rush back in again. All right, so what we call that phase when sodium rushes into the cell and then it immediately becomes inactive, we call that the absolute refractory phase, meaning there is no way, absolutely no way, this cell can be active without going through its process. Okay? And that's what this phase is. And that's the 0 phase, okay? Once we hit that 0 phase, we go to phase 1. Now, phase one is the notch phase, is when you see that notch of the waveform. It starts to notch up, right? As we start seeing that notch, that's the transient opening of these potassium channels now. Now we're going back to potassium, the other ion. I kind of like to refer to these ions as, sodium is the excitability, the exciting ion. As potassium, he's the chill ion. He's just like, don't want to do nothing. He's just chill, very passive, never gets excited, right? He's from Colorado, guys. I don't know if you know that, but potassium's from Colorado. Some of you guys should pick up my joke there. But anyway, it is predominantly a repolarizing ion. So he creates no excitability. So in this phase one, and this notch that we refer to as the notch or the notching, it's actually when those channels kind of start to rapidly repolarize. All right, that's this phase. Okay, now therefore the set is starting to is resetting the mechanism potential of the plateau phase. All right, so in other words, greater potassium during this phase allows more repolarization. All right, we probably see that notch on an ECG as the T wave, right? The notch. So guess what? The more potassium, the more notching, the higher it becomes. The less potassium, well, the less we'll see that notch. Okay, so that's that phase that we're going to see. All right, so we know a lower notch is, well, less repolarization. A higher notch, a lot of repolarization, meaning more potassium. So, it's going to really be hard when you have a lot of potassium for these sodium channels to repolarize, so sodium could come back in and depolarize. Okay, so with that said, we talk about plateau too, the second phase, right? The repolarization. If you look at my slide here, it says recovery state. We want to recover at this point. So now we got the plateau. That's how we start to recover. So how we recover? Think about it. Just think about the word recovery, right? You have surgery. How do you recover? You don't move. You relax. You stay in bed. You do nothing. So that's this plateau is recovering. Then you say to yourself, well, Felix, how does the cell have the capability of not moving? And it's through what's called, it's an enzyme that we refer to as troponin. Troponin is something, we're going to talk about troponin and troponin mycin. So, which is tropomycin is actually the way to say it. Tropomycin and tropamine is the two chemicals or ions that create this plateau, allows this plateau. All right, so the troponin is actually what calcium could bond to. So think of troponin as, think of a picture, right? You hang a picture on the wall. The worst picture to hang up is the one that has one little hook on one side, one on the other side, and we got to kind of measure to make sure we get the same hook, and then we got to hang the picture on those two hooks. I don't know about you guys, but most of the time with me, I'm a little off, and I look at my picture, and it's sideways. So troponin is kind of like the nail in the middle, and then the tropomycin is the rope. That we put from one end, it ropes over to the other end. So the rope is the tropomycin that actually blocks the ability to keep it from being imbalanced, right? So, and then you put the nail in the middle, and now we can balance the picture. So think of the troponin as the nail, and think of the tropomycin as the rope. So, as I mentioned, calcium bonds to the troponin. Now, the troponin, what it bonds to is the actual nail that keeps it from moving, right? The tropomycin is the rope that ropes those myocytes, right? The muscles that ropes it and kind of keeps it. So if you think about the rope is around it, keeping it from moving. So troponin is blocking, tropomycin, I should say, is blocking the mycin from entering. Mycin is what's gonna make muscle move, make this stuff move. But we had a plateau where we don't wanna move. So we put the rope around it, tropomycin, and then we nail it, troponin, and guess what happens now? It doesn't move. But what makes it so strong that's not allowing to move and keeping that force of contractility is that calcium bonding to it. All right, the ability of calcium bonding to that allows that to happen. And then, so with that said, the more calcium you have, the force and strength is going to be less. The less calcium, less is going to happen, and then the sites can start firing all over again. So that's how we keep the plateau, right? That tropomyosin not allowing the heart to contract. But then when the calcium comes and it enters, it's gonna like boop, pop it, right? Kind of pop that nail, right? That troponin. Then now, guess what can happen? Boom, we got a force of contractility. And then now we get into the phase 3, which is the repolarization. So that's why in the plateau phase 2, you see a plateau across because nothing is keeping it at that state and the recovery phase. And then the calcium will help release that and make that happen, right? So in phase 3, the repolarization, as calcium channels start to close, as calcium channels start to close, potassium now becomes very successful in the repolarization of these cells. All right, so during the phase of sodium channels in the beginning of the recovery, they become inactive. Remember I said that? As soon as it goes through, they become inactive. This potential now becomes negative. And when it becomes negative, it allows the cycle to restart. So when sodium comes in, that's the positive, making them fire. The negative is allowing the ability to recover. All right? Then once we hit phase 3, guess what we end up back? At phase 4, which is what? The beginning. That's why we say we start at the beginning, we end at the beginning. All right? So let's talk about some of these electrolytes that are super important that I want you to focus on, okay? So there's a mnemonic called Sexpin. I didn't make this up. I just seen it. I thought it was pretty cool. But Sexpin is a way to quickly identify the major 2 electrolytes, which is sodium, potassium. So the S of sex stands for sodium. The EX stands for external. So it means sodium sits outside the cell. It's external. As the P is for potassium, the IN is internal. So if sodium sits outside, then potassium has to sit inside the cell. So at its resting potential, sodium should be outside, potassium should be inside. So what is potassium represented by? What letter is represented by the letter K? Okay, and the letter K is potassium, right? For kalemia, and kalemia is the K. So you can see in my slide right here, K, right? So it's intracellular. So another way, if the sex pin don't work for you, another way that I remember this is Circle K. Right? Everybody know the gas station, Circle K. So think of the circle as the membrane, and who's inside? The K. So potassium is always going to be an intracellular ion, as sodium will be an extracellular ion. So let's get into potassium. Let's talk about potassium. It is the major, as I just said, it is the major intracellular ion, as we all know, okay, it's the most abundant ion inside the cell. It plays a vital role in the transmission of electrical impulses in the cardiac as well as the musculoskeletal system, okay? It plays a role also in balancing acid-base equilibrium. It plays a huge role in that, all right? In the state of acidosis, hydrogen ion will start to increase. And as that starts to increase, we have a problem. And if this happens, it could force potassium out of a cell. So that's not a good thing. So what happens if I'm in a state of acidosis. I have a metabolic acidosis. I know now what's going to happen in my cell. It is going to force potassium out. So my levels are going to decrease inside my cell. And guess what they're going to increase? I'm going to have high potassium levels outside the cell. To put this on pause and hit a side note, I had a student one time tell me, he was like, Felix, I struggle with the electrolyte levels, with serum and all that. And I realized, oh my God, I never really focused on that. And I really thought that's something people would know, common sense. And I apologize because there's really no such thing as common sense, when it comes to stuff like this. This is really complex. So when we stick an IV in or we put a catheter and we draw blood, we're drawing blood. We're not sticking that IV catheter inside the cell. We're drawing the blood. So that's extracellular. So we take that blood, we run it through the machines, and we get numeric values. So if we know that potassium sits in a cell, and I'm not drawing blood from or drawing electrolytes from inside the cell, I'm drawing it from outside the cell, and we know potassium sits in the cell, then my potassium level should be low. Because where should all the potassium be? Inside the cell. It should not be sitting outside the cell. That's the serum. That's where we drawing blood. And when you draw blood and I got a high level of potassium, well, either one or two things are happening. I have a significant amount of potassium that all my intracells are filled and now is leaking out into the cell. No good. No way potassium should be outside the cell high. Why? Who sits there? That is sodium. If now we start jacking up that electrolyte, we don't want to do that. So that's one reason we got a huge problem. If potassium is the dominant, potassium is the dominant in the cell and dominant outside the cell, well then where is sodium dominant? He's not. So guess what we're gonna have a problem with? Excitability. Well, how are the cells gonna be excited and cause electricity to fire if we are not the dominant outside the cell? So that becomes a problem. What's the other problem that potassium could be high? Is what I just said, in acidosis. Because what does it do? It forces the potassium outside the cell. It pushes it out. It pushes it from inside his house out. Think of acidosis as the evictor. He's evicting them out of their house. And now they're homeless. They're sitting outside the cell. So now we got two problems. He's the dominant outside the cell, and there's nothing in the cell, so we have no equilibrium. We have no balance. That's a huge problem. That's what acidosis can do. So with that said, as I mentioned, I kind of want to recap, and I really apologize on this podcast if I'm being redundant. But we said potassium is the intracellular ion. So it should be high if I ever drew values inside the cell, but we don't. We draw values from blood, and that's outside the cell. So I always expect potassium to be a low number when it comes to its value, and it is. So 3.5 to 5 milliequivalents per liter is what I should see inside the extracellular space. So when you draw blood, if I have a blood value of anywhere from 3.5 to 5, that's good. That's how much potassium should be outside the cell. Because why is it so low? Because potassium is where it needs to be, inside the cell. So as I mentioned, we gotta maintain these balances. So what are the indicators for potassium? Well, if it's elevated, well, I got a huge problem. I might have an electrolyte imbalance. You know what that can do? That could affect the heart's ability to what? Contract. As I mentioned earlier, right? If there's too much potassium outside, then how sodium is gonna get excited? He's not the dominant no more. So potassium is running in the cell and he's running things outside the cell. No good, no bueno. So we have a huge issue there. So guess what happens to the heart rate? It starts to slow down because sodium is not doing its job. All right, so we gotta monitor acidosis as well. We also gotta watch the patients on diuretics, or if they have high potassium, if that's the issue and the heart rate starts slowing down, they might even consider giving this patient diuretics to get rid of the excessive amount of potassium. Because when we get into urology, kidneys is responsible for help balancing potassium. All right, he gets rid of excessive potassium and he maintains potassium where he needs be. So sometimes we'll give a loop diuretic. Don't worry too much of what that means today because we're going to talk about urology. But a loop diuretic is a very potent, very strong diuretic that causes diuresis, that causes the fluid to just get rid of it. So the body's going to get rid of not only fluid, but potassium. And that's how we're going to balance that. Okay? So we're going to talk more about that when we get into urology. All right? So these are the levels, as I mentioned, right? So Three and a half to about 5 is where we like to be. When I see that 5.5 to about 6.5 milliequivalents, now we have a much higher potassium level. That means we have a lot of potassium outside the cell for some reason. We're going to remember we talked about that. That's the influx of potassium. So now we know we see the peak, right? So as we see that peak, we're going to see that T wave really start to peak, right? So that's what we're going to start to see. So the higher the peak wave, or the T wave, I should say, the more it peaks, the more potassium this patient is going to have. So we use a terminology for what we know potassium is called kalemia, right? So a high level potassium, we call that hyperkalemia, all right? That's where the K comes from. But when you start exceeding 7 milliequivalents per liter, that is truly high. You're actually going to have a flattened P wave. Kind of almost tricked you. Think this might be a junctional rhythm. All right. When you have low potassium, it can result in muscle cramping because now sodium is causing a contraction, right? So now it's keeping those muscles in a state of contraction. We talk about myosin, right? We talked about all that stuff that we earlier in the earlier slides. So now we start cramping. We start losing could lose some of the reflexes. Could be nausea, vomiting. We can actually have orthostatic hypotension because the muscles of the vascular system are going to struggle on constricting and dilating, right? So going from a supine position, we have no gravity. As I stand up, I add gravity, but because my muscles or my vessels could constrict, it maintains that cardiac output, maintains that pressure. If I start losing that potassium, I can't balance that. So you can have orthostatic changes, okay? So with that said, high potassium levels, severely high, could cause cardiac abnormalities. As I mentioned, it can cause bradycardia, believe it or not. It can cause bradycardia. You can look like to see some intraventricular blocks, AV blocks, heart blocks, things like that. And it could be something as potassium is through the roof. So we're gonna dive a little bit more into this as we go through paramedic school, because as I mentioned earlier, right, in urology, we know kidneys are responsible for filtration. So if my kidneys are not working, then how are you balancing potassium? As your body accumulates high levels of potassium, it's the kidney's job to get rid of it. But if my kidneys are no longer working and are not producing urine, then how am I getting rid of potassium? You're not. So somebody with end-stage renal disease, this is one of the biggest things I worry about, is becoming hyperkalemic. And we're going to see the bradycardia. So you see how it affects the cardiovascular system. So you'll see a lot of these systems are intertwined. Problem with one creates problems with others, okay? So it can actually cause atrial arrest. It can actually stop the atriums first from contracting. And then eventually it can stop the ventricles from contracting. So potassium, if it's dominant in the cell and dominant out the cell, there's no excitability. So things start to slow down. Heart rate, everything starts to slow down. Guys, that's what actually the lethal injection is. The lethal injection is first they sedate the patient, humane, and then they inject them with a significant amount of potassium chloride. What they do is they override the whole body system. The potassium in the cell, out the cell is so through the roof that the heart doesn't contract no more because sodium can no longer work. So they go flatline, and that's how they die. And that's the lethal injection is potassium chloride. Okay, so let's move forward. So as we talk about some things with potassium that I just kind of want to kind of lay the foundation a little bit, or better yet, plant a few seeds. As I plant the seeds of neurology, we're going to come back and we'll talk more about potassium again when we get to urology. But we're going to also talk about this when we get to endocrinology, because diabetics, right? We give insulin. Everybody knows that. Is this for diabetes? Well, in these cases of high potassium levels, hyperkalemia, remember your terminology, guys. Terminology is huge. The administration of insulin kind of helps. So insulin, just so you know, shifts potassium into the cell. So guess what he's doing? He's taking potassium back into the cell. Hold on a second. You're probably saying at home, sitting watching my podcast, Felix, how can I push potassium back into the cell if it's saturated already? It's already filled with potassium. That's why it's leaking outside the cell. That's not the patient I'm talking about. I'm talking about the other patient. I'm talking about the acidotic patient. I'm talking about the patient who has end-stage renal disease that can no longer balance potassium, nor can he balance hydrogen. Because kidneys are also responsible for the balancing and getting rid of hydrogen, just as breathing is. So now, what happens if my patient is metabolically acidic? What is that acidosis doing to the potassium in the cell? It's pushing it out. It's evicting it from the cell, into cell. He's saying, you gotta go. And he pushes the potassium out of the cell. So those patients with end-stage renal disease who are metabolically acidic, we know they are hyperkalemic, meaning high blood potassium, because the acidosis pushed all the potassium out. So we give insulin. Because you know what insulin is going to do to potassium that's homeless, right? The potassium is homeless. We're going to give them a home. Insulin is going to push the potassium, is going to shift the potassium back into the cell. That's why we give insulin. Well, let me rephrase that. We don't give it pre-hospital, but that's why they give insulin to hyperkalemic patients who are acidic with end-stage renal disease, because all that makes sense. All the end-stage renal disease patient who hasn't been to dialysis, who's showing signs of hyperkalemia, who we know they're acidic, that all equals no potassium in the cell. So we give insulin so we could move that potassium into the cell where he belongs, creating that equilibrium, creating that balance that the body needs, all right? So that's what they do. The insulin leads to a dose-dependent decline in serum potassium levels. And now you notice I'm using that word serum again, because I want you to know when you hear the word serum, that's the blood. We're testing the blood. What's in the blood? What's extracellular? What does those levels look like, okay? So shift potassium from plasma back into the cell. That's our goal, all right? So intravenous glucose of 25 to 50 grams of dextrose, 1 or 2 amps, so to speak, with the unit of insulin, you might see that going. It's not unheard of. So I don't want you to be like, why are they giving this guy insulin, all right? Also, I want you to know albuterol does the same thing. Albuterol shifts potassium back into the cell. So what that said is, well, if somebody's doing a lot of insulin and they're not a diabetic, like people who lift weights, they like to take supplements that have insulin in it. Guess what that could do to potassium? It could shift it back into the cell, decreasing levels and creating an imbalance of that equilibrium. People who take albuterol all the time, guess what that could do to potassium? It could deplete it. So we can get rid of more potassium than EB. So that's something that sometimes people, chronic asthmatics who are on albuterol a long time, docs might decide, hey, let's draw some blood serum to see what their potassium levels are, okay? So pushing forward, hypokalemia is when we talk about blood serum that is less than 3.5, okay? Now, there are some other manifestations of hyperkalemia. You know, I'm talking about the cardiac patient who the kidneys are not regulating or maybe regulating. Maybe they on too much diuretics, right? They're taking diuretics too much, too fast. That's getting rid of all the potassium. That's a possibility. But these patients could develop muscle weakness. And believe it or not, hypokalemia could develop rhabdo. And they could develop rhabdo where the body now starts breaking down muscle. And that is horrible. You know what rhabdo does to kidneys? Man, it can shut them down. And that's when you see they have that really dark, we talk about very yellowish, dark yellow, but it can actually come out even almost darker, almost brown. And that's what I worry about. That means that the body is breaking down muscle fiber, muscle tissue, no good. That will kill your kidneys, very toxic. Because what happens, you're gonna start having an increase in ammonia in the body. Ammonia production starts to increase. Guys, let me tell you, once again, we're gonna come back to ammonia when we get into urology. For my global learners, we're gonna come back, trust me. And it all makes sense then. But ammonia is a very, very lethal toxin of the body, probably one of the most lethal toxins of the body. So ammonia is a byproduct of what we produce. So why we don't die if our body produces ammonia? Because our liver does a phenomenal job of breaking down that toxin into something less toxic called urine. And then the kidneys take the urine and gets rid of that toxin that we call urine. All right, so, but it all starts where? At the liver. So that means if I have a damaged liver or liver disease, can I break down that ammonia? No. That's why people with liver failure, hepatitis, those types of diseases, their ammonia levels are through the roof. Why? Because the liver can't do his job. And he cannot break that ammonia down into a lesser toxin called urea, and then the kidneys get rid of it. So we'll talk, like I said, more about that when we get into those emergencies. But what I'm doing is I'm just putting seeds, guys. Call me the gardener, right? I'm planting seeds in your garden of information. And you're going to see it's going to start to grow, all right? So you're going to see that everything together is intertwined, is blended, and one problem could create multiple other problems. So hypokalemia could create these problems. It could alter also the sodium absorption. You know how the body reabsorbs sodium. It destroys kidneys, and it can actually elevate blood pressure. So these are things that we got to think about when we have low levels. So whether it's too high or too low, no bueno, it is not good. All right. So let me go back one slide. Went too fast. So when you talk about hypokalemia, we could have some ECG changes, and those we can see hypokalemia, we can actually see ST depression. And I'm glad I'm talking about this here because in part 2 of cardiology, we're going to talk about ST depression and ST elevation. So can this ST depression be something that's more significant, or could it be that the patient's just hypokalemic? So those are questions we ask ourselves, but we got to do a good history and do a good assessment to determine that. So that T wave could flatten, we can see that. The U wave gets much larger, which comes right after that T wave, which you really don't see. But if you start seeing it after the T wave, we got a U wave, we can start thinking, oh my God, is potassium our issue? Is he hypokalemic, okay? So those things start to happen. We start seeing a prolonged PR interval starts to increase, kind of looks like a first-degree heart block. Is it a first-degree heart block, or is it my patient's hypokalemia? All right, so those are things that we're going to talk about. So as we get into, sorry, I'm moving fast here. As we move into, give me a second, I'm going to catch my slides up. Give me 1 second. There we go. As we move into calcium, calcium is another electrolyte I want to talk about. And calcium is like the muscle, man. I call it the muscle. It enters the heart's muscle cells during each beat. Every time the heart beats, it's going to enter in, right? It works with the enzymes we talked about earlier, right? It contributes to the contractility, to the heart's normal function. The heart needs calcium. Calcium is a bonding mechanism, is a bonding ion, I should say. So it bonds to the machinery, right? Remember the troponin and the tropomyosin, it works with that. It works with the myosin. So we need calcium. It's a significant electrolyte. It works with it. It doesn't work by itself. And what do I mean by that? If my heart's not contracting, it's not working like it should, then what calcium is going to do? It's going to do nothing. It has to work. So do you give calcium to a dead heart? No, it's a dead heart. It's not contracting. I need a heart to contract so calcium can bond to these elements. This is the ion that bonds. If nothing is happening, then what is he bonding to, right? So very, very important is the squeezing element. Remember the tropomyosin we talked about is the rope around it? Well, guess who squeezes that rope? Calcium. And when he squeezes that rope, he creates a contractility. But the rope has to be there. And what I mean by the rope has to be there is the muscle has to work. If not, calcium is going to fail. It has no purpose at that point. So we need that rope there. We need that stuff to work. It's the squeezing ion, so to speak. I don't even know if I can even say that, but that's how I remember it. All right, so it makes the heart pump. So It is one of the abundant minerals, and I don't want to go off on a tangent here and talk about minerals, but I'm very adamant about minerals. Minerals are so important. Me and minerals are like key. I have minerals. I put minerals in my body all the time. Calcium is one of them. Magnesium is another one. Those are minerals. Your body cannot function without it. If your body has no minerals, you are going to have major problems. Period. You don't need a doctor to tell you that, because minerals is an essential part of functionality of the body, okay? So I want you to know calcium is the most abundant mineral in the body, all right? So we can start producing a lot. So a normal range is 8.5 to about 10.2 milligrams per deciliter. That's how it's measured, all right? And it's responsible, again, for the force of contractility. So it works, it determines rate, determines working of the heart, how it works. And it works directly or inadvertently with magnesium, which is also another mineral that's essential. You need this stuff, all right? But I want you to look at that number, 8.5, 10.2, small number. Once again, we are measuring this number by drawing up blood serum. So that number right there is how much calcium is inside the blood, outside the cell. So since that's a low number, well then guess where most of calcium is originating? Inside the cell. So guys, if you have a low electrolyte number, if the normal values are small, low numbers, that's an intracellular ion. If it's a high number, that's an extracellular ion. So potassium, 3.5 to 5. It's a low number. We already know now where it sits inside the cell. Calcium right here. If you look at this slide right here, if you see the number, 8.5 to 10.2. That's a low number. So now we know calcium is an intracellular ion. All right? So let's move on. So hypokalemia. Hypo means low. Calcemia, calcemia means calcium. Right? So if you have low calcium levels, that means we're less than 8.5. Now we're going to start seeing symptoms usually develop when the serum is way, way lower than that. We're talking 2.5 milligrams per deciliter. And what we're going to start seeing, so it has to be really low, but when you have really low levels, you're going to start seeing a prolonged QT interval. So the Q wave, all the way, so the whole QRS, all the way to that T wave is what we call the QT interval. So we're going to start seeing it's going to prolong. So now we start messing with the whole action potential now. Those phases, when you shorten or you longing your QT interval, we start playing with those phases. And we're playing with phases where we have no business playing. Remember we talked about absolute refractory. We do have a relative refractory. I don't want to play with that. If you start messing those electrolytes and you start playing where you know sodium cannot come back into the cell, the absolute refractory phase, and you start jacking it up, what's going to happen is they're going to jump each other, they're going to ride out on each other, and you're going to have some abnormal electrical firing that you can actually throw somebody onto what they call a Q on T phenomenon. That means your Q wave, your depolarization is firing on your repolarization. Throw you into VFib in a severe or very lethal dysrhythmia. You want to mess with that QT interval. That's when I see drugs like Zofran. Takes a lot. I want to put that out there. Let me put that out there. You need a lot of Zofran to make this happen. Zofran, a lot of Zofran. I'm talking more than 8 milligrams, 10, 12 milligrams. That could play with your QT interval. That's why we only get 4 milligrams. We don't go that high because we don't want to mess with these people's QT intervals. You start prolonging them or shortening them, you're taking a chance. You're rolling dice. I'm not a gambler when it comes to the myocardium, all right? So it could put them, and that's why it could put them into a ventricular arrhythmia. It is rare, but it could happen, all right? So hyperkalemia. Let's talk about the opposite. Let's talk about too much calcium. So we're talking greater than 12 to 15 to start seeing symptoms. It's going to do the opposite. If you know very low calcium causes a prolonged QT, well, guess what a lot of calcium can do? It can actually shorten your QT interval. So very, very, very important to understand that. As I said, this is a mineral, right? The most abundant mineral in the body. What did I say about magnesium? Also a mineral. And it works inadvertently with calcium. Because it's a mineral and it works inadvertently with calcium, they have the same problems. Hypomagnesia, it's going to prolong your QT interval. Hypermagnesia, it's going to shorten it because they're the same minerals that work inadvertently. So you can see the same problems. So can this be a calcium issue? Yeah. Could it be a magnesium issue? Yeah. So what could produce, if you saw the slide before on the hypocalcemia, I say it's rare, but it can cause ventricular dysrhythmias. Guess what low levels of magnesium can do? Could also cause ventricular dysrhythmia. Torsades de pointes, polymorphic VTAC, low levels of magnesium can cause that. So how we fix that? If they're hypomagnesic, we give them magnesium. That's why we give magnesium to torsades, because that's most likely the problem that's causing it, because it truly affects what I'm talking about. Okay? So when the myocardial contractility may initially increase until calcium levels reach greater than 15%, things are going to start to shut down. We got a major problem at that point. All right? So let's continue on. All right? When calcium levels is greater than 15, we start seeing myocardial depression. We don't want to see that. Last thing you ever want to do is depress the myocardium. All right, we never want to do that. We're going to start decreasing automaticity. That's the ability for sodium to cause an influx of sodium influx into the cells. The channel's open. We start showing that rate's going to start slowing down. Eventually, we're going to get to the point where they're going to be asystole, and they're going to have no electricity. That's no good. No bueno again. All right? So keep that in mind. All right? Magnesium, kind of got into this a little bit, kind of segue right into it, right? It is also a mineral. It is necessary. It is needed for the movement of sodium. He's the gatekeeper, guys. I like to think of him as the guy with the key. That sodium channel cannot open unless we have the key. Magnesium is your key. You don't have no magnesium, he's locked in. Sodium stays locked in. All right? So sodium cannot move. So we gotta have a balance. We need it. So potassium, calcium, in and out of the cell, that's the key. The only way sodium, potassium, and calcium are gonna move inside the cell is if you have magnesium. If he stays locked in, torsades, we got an issue. We need keys. How do you get keys? We give them magnesium. All right? So when a patient is hypomagnesia, has very low levels of magnesium, it is impossible to correct intracellular potassium deficiency without correcting magnesium. You're trying to fix something that you can't get into. So the way we get into is you need the key. I can't go to a call and help somebody if I can't get in the house. They gotta let me in. That's the magnesium. If they don't let you in, we can't. So magnesium is an essential. It is essential. It's a mineral that your body needs, period, guys. Period. Now, look at the numbers. Look at the numbers. 1.5 to 2.5 milliequivalents per liter. Is that a high number or low number? It's a low number. So guess where he resides? Inside the cell. He's an intracellular ion. All right? Hypomagnesia, if a patient has low levels of magnesium, ECG changes are identical to hypercalcemia. Not calcemia, hyperkalemia, I apologize, which is potassium, right? Low potassium levels. Heart rate's going to slow down. They become bradycardia. You can see heart blocks. It can prolong QT interval. Could cause ST depression. Kind of the same things that you see in hypokalemia. All right. When it comes to you can widen your QRS. You widen your QRS, that's bad. It's like a ventricular rhythm. That's the torsades. That's the torsades. That is the torsades. So when you see torsades, we want to give magnesium immediately. What are you going to correct if you can't open the door with the key? Nothing. We've got to correct the door first. We've got to open the door first. As I mentioned, magnesium is the key to that door. So before we fix any potassium problems, we got to fix the magnesium problem first. That's why in torsades, we give mag immediately. You can shock them all day. If you don't fix it, but if you don't open the door, you're not going to fix it. So you can shock all day, ain't going to happen. I could bang on the door all day, doesn't mean it's going to open. You have to correct the magnesium first. All right? So let's hit my next slide here. Hyper high magnesium levels, it's kind of going to do the opposite. It's going to increase your PRN2, so it's going to shorten your QT interval. All right? You can have various degrees of decrease in P wave morphology, right? Also the T wave. So it can actually present like a heart block, and it could progress quite quickly into asystole if you have too much magnesium in your system. So it is a balance we need to maintain, okay? Sodium. So if you notice, I talked about first all the electrolytes that are intracellular. This is the electrolyte, the ion that is extracellular, outside the cell, versus the other ones we just talked about, intracellular, right? That's the big difference here. So sodium is Na, and people say, well, Na, Holland's got Na, why isn't that SO, right? Because sodium is represented, we call it natremia. So the Na, so hypernatremia, hyponatremic is low levels of it. So it is an extracellular ion. It influences the serum of osmolality. I always have a problem saying that word. And what do I mean by that is real simple. Simple. Water cannot move without sodium. So, if for instance, I drink regular water from a fountain or bottled water, it's not much sodium, zero to no sodium in it. But when you drink it, it goes into the system, it's going to look for sodium. And if you have sodium higher in your cell, guess what he's going to do to that water? He pushes it in. If I have sodium higher outside my cell, guess what he's going to do to the water from the cell? Suck it out. So that's what we mean by that. It balances, has the ability of sodium balances water. All right, it moves, it influences the movement of water. All right, so open up the cell membrane channels and starts the action potential. Now we start seeing what we call the sodium potassium pump. That's what that is. It starts moving these things. So once the sodium channels open up, guess what sodium could do? Move in. And once again, what happens quite quickly, almost immediately to that channel? Inactive. So can it repolarize? I'm sorry. Can it depolarize again? Nope. Not until it repolarizes. All right? So hypernatremia, believe it or not, this is the bizarre part, right? Hypernatremia or hypernatremia really have no significant impact on ECG. You know, it does on your blood pressure. All right, a lot of sodium will give you high blood pressure. So just FYI, that's another animal we could talk about, but really has no impact on your ECG like the other light. So what has the most impact on ECG dysrhythmias is intracellular ions. All right. So just get into quickly electrophysiology. Let's just dive into this a little bit. All right. When we talk about electrolyte, we're talking about the depolarization, right? Muscle fibers are stimulated to contract. So all that stuff we just talked about, the electricity, we hope that it's enough to stimulate mechanical. You know, so that's what this means. The muscle fibers should be stimulated by the electricity. I mean, I'll give you a good example. Might not be the best example, but it's my example. You go to Home Depot, you get yourself 2 plugs. You get yourself a 220 plug and you get yourself a 110 plug, right? Just go to that section, electricity. You got the copper ends exposed, right? Well, you take it home, you plug in the 110, right? And then you hit your butt cheeks with it. Boom. What happens to the muscle? It contracts. What caused my butt cheeks to contract? The electricity. Now, I take the 220, do the same thing. Boom. Now, my butt cheeks contract so much, it's like a significant contraction. Why was one stronger than the other? Because the electrical current was moving faster and stronger than the other one. And that's why it's so important that electricity moves fast, direct, and quick, man, lightning speed, to cause the electricity, the muscle, to stimulate all at once. That's going to create is going to maximize the force of contractility. And that's that 220 we're looking for. All right, so that's what that does. It helps create that. So when the polarization is normally, it sits anywhere from probably about negative 70 to approximately 90, maybe 100 millivolts. So, and when we get into class, and when you hear my other future podcasts, I always like to start at negative 70 millivolts. Why? I'm talking about the minimum. Anything less than that, it's going to affect the force of contractility. You need that negative 70 or higher. What's ideal? 90 or better. But 70 can create the job and do the job as well. All right? So we have the refractory phase. So the absolute refractory phase, as I mentioned, is a phase where absolutely you cannot, there's no way the sodium channels can be activated because they quickly deactivate. You have to repolarize to activate again. So we have what's called the absolute refractory and the relative refractory. So absolute means you can't do it. Now the relative means I'm in the phase of repolarizing. We're in the phase of repolarizing, and if something can stimulate, since it's repolarizing, it's starting to charge again, is getting ready to allow sodium rush in. Something happens, boom, sodium rushed in. It could fire on that relative refractory phase. And then, but doing that, you could throw that balance, those phases out of whack to 0 through 4, that could create produce some lethal dysrhythmia. So it's not a good thing, okay? So, and that ECG concept is, we're talking electricity always wants to move towards its positive. How? Directly. Because the more direct I move towards that positive, the current is at its strongest. That's the 220 that I referenced of going to Home Depot getting a 220 outlet. I could move towards the positive, but not so direct. Kind of move towards the positive, but not directly. Well, now I'm talking about the 110. 110 is enough to produce electricity to give us what we need, give good current and contractility, but we like the force, we like a stronger contractility. Now, if I start moving towards the negative, the opposite happens. The force of contractility is no good. So we never want to move towards the negative. We always want to move towards the positive. We want to move towards the hypertrophy is what we're trying to do. And that's what my picture right here is showing. So if I'm moving directly towards the positive, my deflection is going to be severely upright. If I'm dead set in the middle, you're going to see upright and a downright. If I'm moving the opposite way, you see a downright reflection. So with that said, that's going to be my segue into part 2 of Advanced 12-Lead ECG, talking about these ECG concepts, talking about how electricity moves towards the positive. All right? So I hope this electrolyte podcast of the cardiovascular system kind of sheds some light on how these electrolytes are so significant to the heart's daily function. My name is Felix from Orlando Medical Institute. I hope you enjoy this podcast. Stay tuned to part 2 of my 3 podcast series.
Orlando Medical Institute podcast.